This chapter covers the application of Componeer in daily routine. In other words, simple to moderately difficult cases, how, where, and why we reached our objectives. In this initial situation, we can see that the occlusion line does not match the lip profile. One can clearly see the inverted course versus the upper lip. The teeth are too short and we need to lengthen them somewhat. At the same time, they have a steep angle. This means that we can place Componeer without preparation, only with sandblasting and etching. This means we can do justice to the lip profile and the dental arch is rounded. However, in this case, we also have to deal with uneven tooth shapes in addition to the lip profile, which does not correspond to the occlusion level. We can see a somewhat too short lateral incisor and, in particular, a deviation in tooth crown axes. Everything is shifted slightly to the left. We therefore need to extend the 2 and the 1 at the same time to angle the tooth crown axes optically and reintegrate them. To do that, we need space. This old filling was extracted and gave us the space to shift the axial angle of the teeth slightly to the right again. One can see the matrix and the dentine. The tooth will be worked up towards the center to correct the central line. In cases of central line shifts or dental axis corrections, it's always recommended to take dentine mass as the first step so that Componeer can then be placed easily at the correct axial angle. This is how the situation between the lips and the teeth is harmonized again. This case also demonstrates a slight imbalance, although correlation of the occlusion line to the upper lip is not that bad, really. However, false coloring causes an imbalance. In addition, the anterior teeth are relatively steep due to the old fillings next to the central incisors, and the dental arch is not round. This can be demonstrated by the diagnosis in this case. The old restorations were removed, with the exception of this abutment on the central incisor. If the old restorations are fine in terms of color shade, if there is no marginal discoloration, and if secondary caries is not suspected anywhere, then they can be retained. Of course, they must also be pre-treated by sandblasting, silicizing and bonding. But the repair of old restorations is something we will deal with in Chapter 4. First, the old restorations were worked up with dentine mass so that the background is more or less homologated. Then the Componeer is applied. As we can see on the images, left and right are the pencil markings, which were made immediately after placing and curing the Componeer. The patient is moved to a sitting position. Looking into the eyes, I can align the bipolar level or the profile of the nose ridge. All other criteria are not yet tangible, as the rubber dam is still in place. The 3 looks somewhat prominent, so we need to reduce the outer surface a little. At the same time, we also need to even the incisal edges so that this line corresponds to the rest of the face. Lips, nose and eyes. This is a classical example of non-prep veneering. The beauty of this technique is that anterior teeth can be veneered with Componeer without requiring a lot of preparation. In this case, you can see parts of old restorations on the surface. These old restorations were ground down to round off the base somewhat. Then we etch with phosphoric acid and can control this via the frosty white appearance. This way we can be sure that everything has been etched. After conditioning, the Componeers were again tried in. I check whether the contour more or less corresponds to the gingiva and if the length is okay. If a Componeer is slightly too long, this does not matter. It can be ground back at any time. Therefore, it is important always to have enough material so that one still has enough left to work with. The Componeers are now placed. The teeth were only roughened, etched and bonded. The fine corrections are performed at the end. The premolars are reduced slightly buccally to make the alignment between the 3 and the molar harmonious. One can see there is a premolar missing. The axial angles and the length of the central incisors can be marked again. We shorten and modify the contour a bit to give the teeth their corresponding position in the mouth. Now to minimally invasive. It's important to be able to tell the patient, yes, I can do this without a great amount of preparation, even if some incorrect colours exist. Well, some small mottling or hypoplasias, such cases do not require deep preparation. Often it is quite sufficient to only roughen the enamel surface to correct this. One can see that the middle incisor lacks contour somewhat distally. We can see the step in the gingiva. The tooth is somewhat retarded. This means that both incisors need to be brought to the same length. We can illustrate this with the diagnosis. A bit is added distally and here at the incisal edge, and the two twos are built up buccally. And with that, preparation is completed. The white dust represents the aluminium oxide that was used to sandblast the surfaces. This was followed by etching, conditioning, and finally all that needed doing was to apply the Componeers to the surface. These are then trimmed back slightly as we had too much material initially. The less we prepare, the more we of course come outwards with the Componeer. We need to calculate this in advance. Is it fine the way it is, or do I need to reduce the surface a bit more to harmonize the dental arch? In this case, everything is fine as we had to come slightly forward with the lateral incisors to compensate for the position of the central incisors. We did not want to grind off too much from the central incisors, and this completes the rounding of the dental arch. And here's the diagnosis again. There are no unattractive teeth. Things are just too crowded. We have an opening lip and the corners of the mouth face outwards. And here we already have the canines. One would normally expect these to be further back. So we have a rather narrow situation. One will need to slightly round out the dental arch to increase the presence of the smile. The advantage of this procedure is, of course, that we hardly have to do any preparation. All that's required is sandblasting, etching and bonding. Then the componeers are mounted with the same material they are made of. If there are no contrasts in the background that need to be blocked, then the componeers can be placed with white opalescence, as in this case. One uses the material from which the componeers are made. It also has the same color shade. This allows the procedure to be minimally invasive or practically non-invasive. In this case too, we have broad corners of the mouth. Actually, the premolars are missing on the left and right. This is why the entire jaw looks somewhat sunken. This often occurs following orthodontic treatment. For example, if the premolars are extracted in the maxilla and the mandible due to lack of space. Here we can view the diagnosis. At the same time, the old restorations at the surface are removed and the dental arch was widened slightly and rounded to create a more attractive situation. This case demonstrates several problems at once. Strong pigmentation of the lip and the gingiva do not worry us. This just makes the teeth look brighter and whiter. However, we can see hypoplasias on several teeth, both in the maxilla and the mandible. Work has already been performed on these, and it has attempted to cover them with composite. But not 100% successfully in terms of aesthetics. We can also see incorrect axial angles of the teeth, and we have incorrect crown lengths to represent the lip profile. We therefore treated the teeth and removed the old composite. Here we can again see how etching and bonding is performed, as described in the introductory chapter. Etching was omitted in the critical areas where one was not sure whether this was dentine or enamel. Like in this cervical dentine area. Enamel was only etched where one was 100% positive. In the critical areas, be they interdental or cervical, one applied one-coat bond self-etch prime and bond primer, as it etches dentine reliably and also allows treating the tooth enamel. This way, we can be sure that bonding took place both in the cervical or interdental area. And then we said, okay, but we have the wrong contrast line. This contrast line needs to be completed. So one takes some dentine mass and works up the contrast line. Basically, this can be done palatal by hand in small portions. This way one obtains a homogeneous subsurface under the componeer, which represents the last layer. In terms of selecting sizes, we can see that the length of a medium componeer is adequate. Then the componeer was placed. Well, what you can see on these images is that the matrix is angled to one side. Due to the composite in the background, it can happen that the matrix deviates slightly when placing the componeer, or is angled slightly distal or mesial in the interdental space, as the teeth do not stand 100% next to each other at the contact point. This makes the matrix appear slightly angled. This demands incisal control to ensure that the second componeer is also in the correct position at the contact point. In other words, if it is angled, one would need to push in mesial direction with a spatula or placer to position the matrix straight again, so that the componeers are also straight again. At the bottom right, the componeer is shown cured, and the matrix stands straight. If this had not been corrected, then the teeth would again stand in the wrong position. The teeth are now aligned. Then it was decided to optimize the mandible, as well as hypoplasias and gaps were also present there, and not all the teeth were quite in the correct position. In the top right of the image, one can see well that deposits are often difficult to spot when the teeth are wet. But that is misleading. Calculus can often have the same color as the teeth themselves. In a dry work field or dry environment, you can then suddenly see, oh yes, there are still deposits on the surface. These need to be removed as the bonding would otherwise stick to the calculus. This is possible, but calculus does not adhere to the tooth as well as bonding to the calculus. Therefore, it makes sense to remove the calculus. Here, a different rubber dam technique was employed. The rubber dam was glued to the gingiva in the maxilla. Gluing in the mandible is often not that easy, as one does not need the contour of the gingiva. It was decided to know the ligatures lingually and hold the rubber dam down buccally. Of course, this only works if the teeth are tapered downwards. If we have the wrong tooth shape without equator or cervical cincture, then this will not work. Contact points can be created in different ways. There are domed matrices, but one can also use straight matrices. This place is suitable for creating an attractive curvature and especially not to produce too much palatal and lingual excess. It is fitted with a silicone stud, which has a curvature corresponding to the palatal and lingual curvature. This allows pressing the composite down to create the base and the background for componeer. Again, one can see the matrix is placed in the sulcus, is retained in position using the placer, and is then filled with composite. This is the base for placing componeer. Here we can see the componeers aligned in a row in the mandible. One can also see the nice cervical finish, which means the rubber dam was in the right position. Due to the strong contrast with the gingiva, the situation looks relatively bright again. This all sounds relatively easy, and it is easy. The componeer system is extremely efficient for dealing with normal cases like these. And in difficult cases, componeer is a very good aid. Under normal circumstances, the system offers a time-efficient procedure which is both attractive time-wise for the patient and the dentist alike. This is why we see the clocks superimposed. In this case, reconstruction is as follows. 5 componeers are to be placed in the maxilla, and 4 in the mandible, all in a single session. A diagnosis is prepared in advance, and we can see how the dental arch was rounded. The premolars are also moved slightly outwards, as they were quite angled in palatal direction, and the lateral incisor is offset. 7:32, everything is ready for the further procedure. The teeth are prepared and bonded. Again, one can see that the preparation is not really a major preparation. The 2 has to come forward, the 1 was roughened on the outer surface, and the rest needs to come forward a bit. One could therefore do without classical preparation. And this is what it looks like, prepared with matrices and bond for the matrices. And then a whole brigade of componeers was arranged for placement. Beforehand, the background was again corrected with dentine mass. That means the lateral incisor was built up slightly to round off the dental arch. A touch of dentine was also placed on the premolars, so that not too much enamel mass is applied together with the componeers. In the chapter on colour shade management, we saw that too much translucent mass can cause a grey tone. Here we see the try-in of componeer. Time has progressed considerably, and 3 hours later, the 10 componeers are placed on the surface and worked up. We take a small break, and the mandible is isolated differently. The holes of the rubber dam were cut somewhat larger buccally to then glue the rubber dam to the gingiva with histoacryl. Lingual gluing is not necessary in this case. Stretching the rubber dam to buccal, it holds lingual contact and isolates the work field. Buccally, we have the freedom of conditioning and being able to work up to the cervical region of the gingiva. By and large, we only sandblasted as the occlusion made this possible in this instance, placed the componeers on the teeth and corrected the line. All componeers are placed. Followed by finishing. And now it is 12:33. We started treatment at 7:33, some 5 hours later. The maxilla and mandible are equally restored with componeer. This is to demonstrate to you that this is a very efficient system. Every other system that could be employed here, both direct and indirect veneering techniques, would require considerably more effort in terms of time.